So our last presenter for this session is going to be the paper Concordance between point of injury reports and findings on arrival at a forward surgical element in Afghanistan. That's being presented by Major Timothy Plackett.
All right. First, I'd like to start out by thanking the programming committee for the opportunity to present our data today. And we're going to be looking at what happens between the point of injury and what shows up at your FST or whatever equivalent you have, and is there any correlation between the two of them? We have no disclosures to make, and these are the opinions of myself and my co-investigators. Triage and medical evacuation have been cornerstones for battlefield medicine, and our principles were really elucidated during the Napoleonic Wars. But since then, we've stayed with the same message of the right patient to the right place at the right time. And while we've been working on this, everything's been kind of codified through what our opinion is of what it should be, and it's never really been externally validated. So our current system is based on the medic at the point of injury making a determination of how injured is this patient and how long can we delay their definitive care, 1 hour, 4 hours, 24 hours, or is it a flight for convenience? As a surgeon, this creates quite a bit of frustration sometimes when the patient shows up. So we wanted to ask, is that really the best way, the most accurate way we have available to do this? Right now, medical evacuations are requested through a NATO 9-line report. This is the only thing required to move a patient. And the only thing you need to have, or the only thing that's going to be on that 9-line, is the number of injured, the mechanism of injury, and their triage category. If you're lucky, you may get a missed report. It may have additional data, like the exact injuries that are suspected, the treatments that have been rendered, and the patient's vital signs. But that's not required, and often when it comes, it's incomplete. So we performed a prospective observational study at 3 forward surgical elements. These were essentially all FSE minuses in the western and southwestern portion of Afghanistan. The study went from February 16th to October 16th, but of note, due to operational requirements, Shindan Air Base ended up pulling out of the study and was no longer enrolling patients after April 12th. What we collected was everything we could find off a NATO 9-line and off a missed report that was relevant for the patient. So the number of injured that we were getting, the mechanism of injury, the injuries, the vital signs, and most importantly, the triage category. We then compared this to what showed up at the FST. The comparison for vital signs was the very first set of vitals recorded in the medical record, and the treating provider was asked, after all care had been rendered, to make an assessment of how long could this patient's care have conceivably been delayed without harming the patient. They then referred back to what at the time was Field Manual 4-02.2 as their point of reference and said, what was the actual triage category for this patient? What was their actual need? We then performed a Cohen's Cohen's kappa statistic for correlation between everything that was on the 9-line report. And then for the information that comes off the missed report, and in particular the vital signs, these are repeating measures, so we performed a Pearson's correlation to look for this repeated measure. In total, there were 179 medical evacuations, and what you see is that there's about 1.5 patients per evacuation. This really translated into somewhere between 1 to 6 patients on each transport. Not every patient had a missed report. Everyone did have a 9-line report, and you see some of the information that was missing off of the missed reports up there. When we encountered missing data, we did not censor that patient, nor did we perform any imputation. We just used the data as it was available to us. Much like the last study, you see these are overwhelmingly young males. The majority of patients were injured in a blast injury, and what's not captured up here is most of these were local nationals, and these were IED blasts. So getting into what we were most interested in, the triage category, triage was actually fairly accurate. Accuracy was there 80% of the time. We did have 6% under triage, and this is the most concerning part because these are patients that in a resource-constrained environment might not get to the right place at the right time. So this is the area that we need to think about trying to improve on. We did have over-triage, but this is kind of what you have to expect if you want to minimize under triage. And the kappa statistic was 0.619, which is suggestive of moderate correlation, which is generally considered pretty good. When you look at this as a function of what was our actual triage category, you see that our accuracy starts to drop off as you get into the lower categories for the patients. As far as the number of patients that you were going to receive, This is fairly accurate. The Kappa statistic was 0.85. This is suggestive of almost near perfect agreement. And if you were told you were getting 1 patient or 2 patients, that's all you were getting. If you got told you were getting more than that, you may get that number, you may get less, but very rarely, only 1 case did more than 1 patient actually show up in addition to what you were told about. The mechanism of injury, as well as the body region that was injured, is highly accurate. We did not go down into the exact injury level, so this would look at head, chest, back, abdomen, each extremity separately. But as far as was it a tibia injury versus a femur injury, that we didn't dive into. But the region, at least, is accurate. When we look at vital signs, we start to see something different. So on the x-axis, you can see the pulse at the point of injury, and on the y-axis, you see the pulse at the roll 2. The red line is a 1-to-1 correlation. Ideally, if nothing changes with the patient, that's what you should see. And you see a clustering effect. We get close to a 1-to-1 correlation. But in reality, when you look at what happens from point of injury to the roll 2, there's a statistically significant difference in the pulse. And we asked, why was there a difference? So we looked at this from a different standpoint. And on the x-axis, it's the pulse at the point of injury. And on the y-axis, it's the change in pulse over time. And there's really 2 distinct groups that we can identify. If your pulse was less than 100 when the 9-line report and the missed report was dropped, your pulse probably was going to go up over time. You were going to get more tachycardic. If your pulse was greater than 100, it was going to come down. We think this is suggestive of what should be going on with our balanced resuscitation with permissive hypotension. And I'll show you the mean arterial pressure data next that offers an agreement with this. If you are tachycardic, you're more likely to get volume, you're more likely to get more fluids, and the goal should be to bring your MAP up. That should result in your pulse coming down. If you're not very tachycardic, you're probably not very hypotensive, you don't need as much fluid, it's more likely that it may get worse until you reach our triggers to start a transfusion or to start a more aggressive volume resuscitation. So we think this is what we're seeing a hint of. When you look at mean arterial pressure, you're going to see a very similar graph. So the point of injury versus the roll 2, the map kind of starts to cluster at a 1-to-1 relationship. But the p-value for this, 0.03, there is a statistically significant difference between the 2 time points. So there is a difference between the point of injury and what shows up at the roll 2. When we graph this again as a function of the change in MAP over time, you see these 2 groups emerge. If your mean arterial pressure was above 90, someone that many of us would not necessarily pound with fluids right away, your blood pressure is going to fall. If your MAP was less than 90, someone that I think all of us would agree we're going to start being a little bit more aggressive, and we'd expect the medics to be more aggressive with their volume resuscitation, the blood pressure is going to rise over time. Finally, we looked at the respiratory rate, and there's less of a 1-to-1 correlation here initially. There is a statistically significant difference between the 2 time points, but again, we see a clustering of kind of 2 different groups. There's the patients whose respiratory rate was closer to 20 or less. Their respiratory rate would go up over time. And then there's a second group whose respiratory rate was above 20. And although we didn't keep track of which patients were intubated, in general, we would expect that these were patients that were then intubated. And probably the reason that their respiratory rate went down is because they're now being bagged and were being on a ventilator, and now it's being manually controlled. So what we concluded from this was that the 9-line report is fairly accurate, probably better than most of us thought that it was. Triage is pretty good. It could be a little bit better. Ideally, we'd like to see that 6% under triage disappear, but that's going to come at the expense of increasing the over triage. The missed reports suggest that our vitals are not accurate, and that may be where most of our frustration is coming from, that what physiologically we're expecting is something that shows up different. But we think that this is a result of the permissive hypotension and the balanced resuscitation strategy that we're employing. We don't have any volume data to suggest what was actually given to the patient, so I can't confirm that that's the case, but this is really where we think all this is headed. There are a few limitations to point out. First, we don't know what triage system was being used at the point of injury. We know what the field manual says it was supposed to be, and talking to the medics, many of them are unaware that there's an actual doctrinal approach that they're supposed to be using. So while we said this is how the triage functioned, they may have been using a different system. Next, we only included Roll 2s, and we only used RC West and RC Southwest. This was in part due to the operational tempo for there was kind of conducive to being able to collect data, and there were enough lag time for people to really enter in everything that we needed. But these results aren't necessarily able to be generalized to a more busy environment or to one in a different conflict. Lastly, we don't have any patient outcome data nor transportation times, which is critical when thinking about triage and medical evacuation. And with that, I'm happy to entertain any questions.
All right, Dr. Choi.
That was a great talk. I spent some time in FRA in 2013, and I guess their data must have been more accurate than I thought, because I didn't think we had 98% accuracy. But I think as far as your thought on pulse, I mean, I don't think you can ever get an accurate pulse because those things change over time, as long as you get the injuries right. But as looking at why the heart rate drops or the increases and vice versa, the blood pressure, why were you not able to get data on pain medication that they were given? Because that can also affect, and then also the volume status, because when they evacuate the patient, the flight medics have to usually give the info on volume resuscitation and pain meds. So was that just not available, or was not given on in the records?
It wasn't part of what we initially were collecting. It just wasn't part of the thought process of what we were looking at. But moving forward, what I'd like to do is see this get repeated and add in more of the information that's missing with transport time, what were the fluids that were given to the patient, other interventions that were performed, what was the pain medication that was given. This, to me, was a really preliminary set of data that we were trying to look at what is the source of our frustration and can we make this better? And without knowing what the problem was, if there was a problem, we don't know where to start. And so this was kind of our starting point.
Hi, Peter Learn from Walter Reed. Thanks for an interesting talk. I'm wondering if you can elucidate a little bit more about this whole over-triage, under-triage assessment. Were those decisions about whether patients were under or over-triage based off of an interpretation of what they thought the information was available at the sending location, or is it just based off of the assessment of the patient at arrival at the facility? Was there any component of missed injuries or under assessment of injuries? Like, how did you actually tease what was going on with the over and under triage?
Sure. So for the point of injury, it was simply whatever the 9-line report said. And so that was based off of whoever put in the report their clinical impression on the scene. What we compared that to was after treatment had been rendered, we asked that treating provider to say, realistically, knowing the injuries, knowing what interventions you had to do to save this patient's life or to provide care, how long could you actually have delayed that care? Because that's really what our triage is designed to do, is determine how long we can wait to send the helicopter. And so they had the benefit of knowing what the injuries were, what the surgical need was for the patient. And most of these were filled out after, well after, but still the same day, whatever definitive care was provided. So it was usually filled out after the patient had left the Roll 2 and gone to the Roll 3. So that surgeon should be able to say, this patient could have waited 4 hours, this patient could have waited less than an hour, and it should be what the actual need was. And this is kind of a different approach than what civilian trauma uses, because the civilian model is just to say, well, do they need to go to a level 1, level 2, or can they just go to any hospital that has their lights on right now? So it is a very different kind of standard that we're looking at.
So what was your reference standard, though?
The reference standard was FM4-02.2, which is based on the time that care can be delayed. So it says for priority 1, transportation needs to occur within an hour. Priority 2, it needs to occur within 4 hours. Priority 3, within 24 hours. And then priority 4 is essentially convenience. It can go at any point in time.
But I think what he means is, how did you define over and under triage? It sounds like you did it based on opinion of the surgeon, which like you said, it's markedly different than what would be done in civilian or standard trauma environment, which is probably why your triage numbers are so different from standard civilian triage numbers.
So we did go off of what the surgeon said. This is what they could have been delayed to. So it was the surgeon assessment. And our over triage number is actually fairly comparable to what the CCOT says the civilian standard should be, which is 5%. Most civilian centers are reporting somewhere between 5 and 10%.
For over triage?
Under triage.
Okay. Yeah,
For under
triage
triage.
should be 50% generally. So go ahead, next question.
Hi, Kristen Beals, Wilford Hall. Really appreciate this. This is interesting because I think every FST is concerned about the information we get in order to fully prepare for those patients coming in. So I appreciate you looking at this. But my question is, what is your overarching strategy for looking at this? Is this going to drive training at the medic level, change TCCC guidelines for triage, et cetera? What's your strategy?
So the hope is to find an ideal methodology that would eliminate the under triage. We recognize that that's going to accept over triage. And data that I didn't present here because I just don't have a complete set out of this group, we did try to compare this to some other standards. And so if you look at NATO for a MASCAL says we're supposed to be using NIMS. NIMS essentially takes a revised trauma score and correlates it with a triage category. NIMS was terrible with under triage. In fact, there was up to 50% under triage for the category priority 1 patients. It assured that the most sick patients get to you, but it would have taken a lot of people that a surgeon said they needed surgery in an hour and potentially delayed their care. We did try looking at Colonel Eastridge's recommendation from 2012, which was a system based on whether the patient had a palpable pulse, making an assumption that that was roughly a map of 90, and their motor score for GCS. And that I have a much more limited data set, but if we use the gold standards being what the surgeon's assessment was, even that underperformed compared to our current doctrine.
And my second question, if you don't mind, when you do look at the patient outcomes, I think it is critical to go all the way to their outcomes and seeing those under triage patients if that did impact their outcome, because typically at the FST you can overcome and improve the outcome based on bad information, based on your good triage at the FST. So I think that's going to be critical to tease out. So
I would 100% agree with that comment. With our current success with survivability of wounds, I think the number of patients you would need to enroll in such a study to show a difference is somewhat prohibitive right now.
Kirby?
Just one comment. First off, great work. I was out, had a chance to visit you while you were deployed, and I could see your frustration, and a great job following through with that with this presentation. One of the major trends that we're going to be faced with in the upcoming conflicts, at least it's theorized, is a more dispersed battlefield. We, I think, have been spoiled with well-established trauma systems these past 10 to 15 years. But one of the general concepts is that of prolonged field care. And where, for example, if we look at a map of Africa, we can fit about 20 to 22 Afghanistans in Africa. So I think just want to make that point because this is particularly timely. We are moving more advanced resuscitative capabilities farther forward. TXA, for example, where our special forces medics can administer freeze-dried plasma. So these more advanced capabilities, we need to provide them better tools so they can appropriately triage patients. So I think following up on this and perhaps coming up with some better triage for our medics would be very helpful. So thank you.
And look, first off, let me congratulate you on doing a prospective study in a combat zone, which is a rare feat in and of itself, and nice study. Two questions, and I think they get to some of your conclusions, which I would caution you against drawing some of those conclusions, which are based very much on speculation about the change in vital signs. I mean, the change in vital signs are just one thing is you get inaccurate field vital signs, or if you've ever tried to take a pulse in the back of a helicopter, your pulse is the vibratory rate of the helicopter. It's probably not the patient's pulse. So just how are you making that assumption that it's resuscitation, especially since our medics aren't trained to resuscitate to a heart rate? It's, they only get fluids, right, if they don't have a palpable radial pulse or mental status isn't intact. So how are you correlating that the heart rate was different pre and post to this was some difference in resuscitation?
I 100% agree with your statement because I don't have any data to show what the resuscitation was. I know what we traditionally had been teaching as far as permissive hypotension and a balanced resuscitation, but we all know that you can do whatever you want. I can tell you, I can put out a CPG and say you should do this, but we've all sat through the VTCs and people do what they want in the end. Hopefully they follow our recommendations though. If they were following the recommendations, it seems reasonable to make this assumption, but that is, like you said, a leap. It's an assumption. And hopefully the next level study, we can include that and be able to kind of drill down if that is a true statement or not.
All right, any other questions? Okay, thank you. And that'll end our last trauma session.